from which I would call upon Dr. Padma Bhate. She has worked as a coordinator for Sehat for 10 years and has worked on a mental health service research, including standard for care in a private health sector. So she was going to spread light more on this topic. Please welcome her.
Good afternoon, everyone. Sanjita just spoke about the kind of cases coming to the hospitals, largely being recorded as accidental consumption of poison, which are OP poisoning or overdose of tablets. What I'm going to kind of take you quickly before getting into the response which Chitra will look at is the whole issue of burns. And burn injuries are often referred to as dowry deaths is what galvanized the women's movement in the 80s. And it kind of raised the whole issue of violence against women and kind of, brought the whole issue into the public domain. But burn injuries continue to be a critical health issue even today. And a lot of men, women are dying because of burns, largely women. It's a really gendered issue where you have a very skewed ratio as far as, male, female is concerned. There's a huge difference in the low middle income countries and the high income countries in terms of burn outcomes. So you have high mortality because of burns in India and other, South Asian countries. Also, the low degree burns lead to different kinds of disability and disfigurement because of lack of access to plastic surgery and reconstructive surgery. When it comes to looking at burns from a very gendered perspective, one finds that it's actually in 2009, it was found to be the third cause of death for women in the reproductive age group. So that itself tells us, how significantly important issue it is when it comes to women's health. There was a study on estimates done in 2009, which found that there were about 1,63,000 deaths, 65% of them being women. Go ahead. The Ministry of Health has actually estimated it to be about 70 lakhs. And if you go by those 70 lakhs and about 1.4 lakhs death of these 70 lakh total injuries, if you take the 65% estimate, then on an average 91,000 women are dying because of burn injuries every year. So that's much more than maternal deaths, but that's a number that probably we don't even recognize or are aware of. Go ahead. This is an estimate based on NFHS, where women were asked about, domestic violence and also asked about health consequences. And about 12 lakhs women have actually reported that they have suffered severe burns because of domestic violence. So what's emerging from secondary literature and this secondary data is that a large number of women in the younger age group are dying, mostly because of accidents. These are all recorded as accidental burns. And what's questionable is, why is it that so many young married women are dying in kitchens when women are initiated into cooking very early? So they don't die in their marital homes or mica, but they seem to be dying because of accidents in their marital homes. Next. Lot of also women who have suffered burns or died of burns have said that they committed suicide, but it's largely being explained in literature as quarrel in the family or maladjustment of young bride. So these are the kinds of issues. What's missing is any investigation into the cause of death or a completely missing perspective on public health. So if such a public health approach essentially means that if a large number of people are suffering or dying because of a certain issue, then that needs to be taken on and preventive action being proposed. But nothing like that is happening with burn injuries. Go ahead. So this is based on a doctoral work that I did with Tata Institute of Social Sciences. This is my PhD on this topic. I spoke to 22 survivors, 26 providers, and about 8 key informants. What I found was that of the 22 women whom I spoke to, 20 were married, 2 were never married. Of those who were married, 18 women reported some form of domestic violence. 33% of these women died, and 60% confided that the cause of burns was not accident. So this is a table that I would like to have your attention to, because as per medical records, of the 22 that I spoke to, 15 reported accidents. So the medical records and all the entire documentation on mortality will have it as accidental deaths. So they've all said accidental burns, 6 suicides and 1 homicide. When as a researcher, when I spoke to them, then when you see the next row, you find that only 3 actually said they were accidents. Almost, of the 15 who had reported accidents, 2 said they were homicides, meaning somebody had, poured kerosene on them and put them on fire. 7 of them reported suicides. So they reported domestic violence, and they said that they've had enough of it and they can't bear it anymore, and that's why they took this step. 4 of them spoke about different forms of abuse, domestic violence for years together, but they said that I don't know what happened and I think it was an accident. So they didn't clearly say it was suicide or homicide, but the circumstances were not very, they did not explain the nature of burns that they had reported. Next. This is consistent with other studies done where they found that there's a difference in terms of, what the patient has reported to the doctor, so what comes on the medical record versus what is reported to a researcher or a social worker, and that ranges almost 50 to 60% difference in the cause of burns being reported to official, as per official records. Go ahead. When I spoke to providers, and I asked them about the causes of burns, so I would like you to see the third column, where when it came to women, they actually said something like query accidental. So they said, we don't know whether it's accident, but we are supposed to only write what they tell us. Go ahead. What was found through this study was that in terms of clinical care, there's a lack of standard protocol for management of burns in our country. So, there is a certain protocol medically which should be followed, but it's not being followed. In terms of immediate treatment, emergency care, all of that is not really being followed. There's been a huge change in burns care, in the sense that, acute burns, we do have very good specialized centers which can actually manage severe burns. So that level of improvement has happened, but it's not available to the district hospitals and other places where actually patients are brought to. There's this whole issue of this being a kind of, flip-flop between the plastic versus the general surgery. So the plastic surgery, wants to look at it from, a perspective where if the person is going to survive, then they're interested. But if it's severe, they're not interested in treating them. So they're left to die without giving them the standard treatment that is required. And that brings us to this whole thing about salvageable and non-salvageable still being a part of medical care when it comes to burns care. So moment a burns patient is brought in, there is a certain assessment made saying whether she will survive or not. And that is absolutely questionable, because 70% burns can also survive. That there's evidence to that. And that kind of practice still exists, which is very problematic, because women are not even being allowed an opportunity to survive. It's a neglected issue by health professionals and system, because we have a huge human resource crunch. It takes a toll on doctors, because doctors said things like when you do, if you're in orthopedics, that post surgery there's going to be some positive outcome, but with burns there's just, we don't know. So, it's not something which is very interesting, or, it basically causes burnout, and not something that they want to, really engage in. The returns are not high. It's extremely, so plastic, even for plastic surgeons, burns is not their area of interest, because they are more interested in cosmetic and other surgeries than burns, because who's getting burnt are women from lower socioeconomic class who may not be able to pay the kind of money that they'll get through plastic surgery. When it comes to medical legal care, and we need to go back to the women's movement, where the whole law was brought in that within 7 years of marriage, if there's any burn injury, any person who dies with burn injuries, irrespective of what she says, there has to be an investigation. And therefore the dying declaration and all. And the dying declaration, in a sense, was included because it was felt that a person who's dying will always tell the truth. But over the years, there's adequate evidence that women, when they are dying, they may not tell the truth, because they're concerned about their children, they have other concerns, and they still continue to not tell what actually has happened, or who's caused the burns, and why are they dying. When it comes to medical legal protocol, what was found was that there's no preservation of clothes. And I'm sure with the Nirbhaya, all of you would know the forensic role in cases of sexual violence, where actually in most cases of rape, there's no evidence on a woman's body. But here you have a woman who's come to you hospitalized, her body is telling you what the nature of burns is, but there's no mechanism to actually document how the burns has actually, escalated on her body, no preservation of her clothes, nothing at all. The forensic expert comes in after death, at the time of postmortem. By then, the examination of the body really cannot give them any clue on what has happened. So all that was there on the body has been completely missed out. Yeah, go ahead. Providers actually said that there are various markers on her body by which they know that this is not, the whole accidental query business is very obvious, but there's no method by which, and they all kept saying, we have to say what she says. How can we question her? Without, so even when I ask them that if what she's saying doesn't match with the history, don't you put a query saying that it is not matching? No, we don't do that. We are, as doctors, we are only supposed to say what she says. So that's the level of medical evidence that, we have in our country. So that's the missing link, yeah. Completely missing link. And that brings us, and the research work that I carried out really raised the whole question about what is happening to this whole issue of burn injuries, what is happening to women, both in terms of mortality and as well as morbidity. And when I went to to the OPD clinics where burn patients come for follow-up, and I sat in 3 burns wards, OPD wards, like they come to the surgery ward. No women were coming. It was only men. So men do suffer burns, because those are, but largely factory burns. So those are chemical burns, and they do come back for follow-up. But most women are not coming back to follow-up. So the consequences of burns for those who survive is also something that requires an inquiry, and a completely, an issue which is completely missing as far as the health system's priority areas are concerned. The whole injury research has picked up road traffic accidents, because that's common across all countries, and create a certain public campaign to reduce road traffic accidents. But the same has not been picked up with burn injuries, although the injury research clearly found that India has high burn injuries. So that's the larger global politics, where this issue is very, very specific to South Asia. This whole thing of burning is a very peculiar issue, culturally specific to South Asia. So with that, thank you very much.
Thank you, Dr. Padma. Wow, these statistics were really alarming. And when we look at the statistics of the number of death by suicide in India, I think we do not consider this aspect, and it's the places like these conferences where we get to know so much more about all the other variables as well.